Bismillahirrahmanirrahim. On this video, I'm going to talk about the common condition of allergic rhinitis, which can be defined as an inflammation of the nasal mucosa caused by an allergen. It affects 10 to 25% of the population, and it is the most common atopic allergic reaction. It is caused by airborne allergens, which include house dust and dust mites, feathers in pillows and quilts, molds, tobacco smoke, processed materials or industrial chemicals, animal dander, in the spring, tree pollens, in the summer, grass and weed pollens, in the fall, weed pollens, occasionally in the summer and fall, mold spores. Allergic rhinitis is an IgE-mediated type 1 hypersensitivity response to environmental antigen in a genetically susceptible person. Type 1 hypersensitivity causes local vasodilatation and increased capillary permeability. Allergic rhinitis was formerly classified as seasonal or perennial. Current classifications are intermittent when the symptoms are present less than 4 days per week and less than 4 weeks per year. Persistent when the symptoms are present more than 4 days per week and more than 4 weeks per year. Severity is classified as mild when no interference with daily activities or troublesome symptoms. Moderate to severe when at least one of the following is present: impaired sleep, daily activity, work or school, or troublesome symptoms. Complications of allergic rhinitis include allergic asthma, chronic otitis media, hearing loss, chronic nasal obstruction, sinusitis, orthodontic malocclusion in children. Clinical manifestations are variable, and in the nose, the symptoms include mucous membrane congestion, edema, itching, rhinorrhea with clear secretions, sneezing. In the eyes, there may be edema, itching, burning, tearing, redness, dark circles under the eyes. In the ears, there may be itching or fullness. Other symptoms might be palatal itching, throat itching, and non-productive cough. Diagnostic evaluation include skin testing, which confirms a hypersensitivity to certain allergens, nasal smear, where an increased number of eosinophils suggests allergic disease. RAST gives positive test result for offending allergens. Rhinoscopy. Rhinoscopy allows better visualization of the nasopharynx and is useful to rule out physical obstruction, septal deviation, nasal polyps. Evaluation for asthma is important in allergic rhinitis patients. Management is divided into 3 sections: avoidance, medications, and immunotherapy. Avoidance. The patient is advised to minimize contact with offending allergens regardless of other treatment. Reduce dust mite exposure by encasing bed pillows and mattress in allergen-proof covering. Medications. Oral and topical antihistamines are first-line therapy for mild to moderate intermittent and mild persistent rhinitis, and additional to intranasal steroids for moderate to severe persistent rhinitis uncontrolled on topical intranasal steroids alone. Oral antihistamines are effective predominantly on neurally mediated symptoms of itching, sneezing, and rhinorrhea. They improve allergic symptoms at sites other than the nose, such as the conjunctiva, palate, skin, and lower airways. Regular therapy is more effective than as-needed use in persistent rhinitis. Topical antihistamines have a fast onset of action within 15 minutes and are useful as a rescue therapy, but they do not improve symptoms due to histamine at other sites such as the eye, pharynx, lower airways, and skin. Decongestants. These shrink nasal mucous membrane by vasoconstriction and are available over the counter and in combination with antihistamines, pain relievers, and anticholinergics. Topical intranasal corticosteroids. These are first-line therapy for moderate to severe persistent symptoms and treatment failures with antihistamines alone. Topical steroid drops should be used initially in nasal polyposis and severe obstruction. The onset of action of topical intranasal corticosteroids is 6 to 8 hours after the first dose, and clinical improvement may not be apparent for a few days, and maximal effect may not be apparent until after 2 weeks. Starting treatment 2 weeks before a non-allergen season improves efficacy. There is a similar clinical efficacy for all intranasal steroids, but bioavailability varies considerably. Systemic absorption is negligible with mometasone and fluticasone, modest for the remainder, and high for betamethasone and dexamethasone, and these should be used short-term only. Long-term growth studies in children using fluticasone, mometasone, and budesonide have reassuring safety data, unlike beclomethasone. Raised intraocular pressure has been described with intranasal steroids, so patients with a history of glaucoma should be monitored more closely. Systemic glucocorticosteroids are rarely indicated in the management of rhinitis except for severe nasal obstruction, when they are given for a short-term rescue medication for uncontrolled symptoms on conventional pharmacotherapy for important social or work-related events such as examinations or weddings. Oral corticosteroids should be used briefly and always in combination with a topical nasal corticosteroid. Anti-leukotrienes like Montelukast is licensed in the UK for those with seasonal allergic rhinitis who also have concomitant asthma. They might be useful in patients with asthma and persistent rhinitis. Topical anticholinergic can be used as an add-on therapy for allergic rhinitis when watery rhinorrhea persists despite topical steroids and antihistamine. It decreases rhinorrhea but has no effect on other nasal symptoms. Treatment failure may be associated with poor compliance or with poor technique in the use of nasal sprays and drops. Therefore, appropriate training is imperative. If still unsuccessful, the diagnosis should be reviewed and the need for alternative treatment should be reassessed. Immunotherapy. Immunotherapy is considered for pollen allergic patients who fail to respond sufficiently to conventional treatment. It is done by administering subcutaneous injections of increasing amounts of an allergen to which the patient is sensitive to decrease sensitivity and reduce the severity of symptoms. Possible adverse effects of immunotherapy. Systemic reactions. Anaphylaxis is rare but potentially fatal. Local reactions consist of erythema and induration at the site of injection. Now we come to referral. ENT referral is needed for unilateral nasal problems, nasal perforations, ulceration or collapse, blood-stained discharge, crusting high in the nasal cavity, recurrent infection. Allergy clinic referral is needed for inadequate control of symptoms, allergen-triggered identification, to consider desensitization, recurrent nasal polyps, multisystem allergy, for example rhinitis with asthma, eczema or food allergy, occupational rhinitis. Asthma and rhinitis. Asthma and rhinitis usually coexist, with symptoms of rhinitis found in 75 to 80% of patients with asthma. Rhinitis is a risk factor for the development of asthma, and treatment of rhinitis is associated with benefits for asthma. Rhinitis in pregnancy. Rhinitis affects at least 20% of pregnancies and can start during any gestational week. Informing the patient that pregnancy-induced rhinitis is a self-limiting condition is often reassuring. Regular nasal dosing may be helpful. Most medications cross the placenta and should only be prescribed when the apparent benefit is greater than the risk to the fetus. It's a good practice to start treatment with tried and tested drugs. Beclomethasone, fluticasone, budesonide appear to have a good safety records as they are widely used in pregnant asthmatic women. Chlorpheniramine, loratadine, cetirizine may be added cautiously if additional treatment is needed, but decongestants should be avoided. Some antihistamines may increase the risk of spontaneous abortion or congenital malformation. Finally, thank you for watching and have a nice day.